of BDEM is. I think we reached the time now.
Thank you for joining.
So let me give a brief introduction for Dr. Herzig.
Yes.
Dr. Herzig is one of our professors of surgery. He's actually our most senior colorectal surgeon. He's actually an editor for Diseases of Colon Rectum, which is our major national journal. He's in charge of our quality measures for the busiest general surgery division in our university, and actually one of the most gifted surgeons I've ever seen and worked with. So it's been a privilege to work and be his friend. So I'm very excited to hear his talk on low anterior resection syndrome, which is a very common problem, at least for many of our patients.
Thank you, Kim, for the introduction. Let me see if I can share this, and then maybe you can tell me if it, okay. Are you seeing this okay?
Yep, we can see it.
Okay, super. Well, welcome everybody. Good morning. I'm very pleased to join you to talk about low anterior resection syndrome. I thought I would outline, these are pretty, I think, fairly expected what I'll cover in terms of defining it, talking about the risk factors, talk about some of the assessment tools, prevention and management. But please interrupt if you have questions along the way, and hopefully I'll have plenty of time at the end for us to discuss, which I think is always more beneficial than just hearing slides narrated. This is the issue. Low anterior resection is the mainstay of surgical treatment of rectal cancer. It includes removal of the rectum and the associated mesorectal lymph nodes. Since the 1970s, when we had circular staplers, we've pushed the envelope in terms of how low we can resect and how much sphincter preservation we can offer our patients. The consequence of this success is that we have something called low anterior resection syndrome. And it's never good when an operation has a syndrome named after it, but that's where we are. And the only reason people will put up with this is because they prefer it over a colostomy, but that's not always true, as we'll find out also. Since the early 2000s, almost 20 years ago, over 20 years ago, we have treated patients along the lines of the German rectal cancer trial, which defined the benefit of preoperative chemoradiation, followed by surgery and then adjuvant therapy. Obviously, this is much in flux over the last few years, but what we have is 20 years of experience of what happens after you give radiation and then operate and then deal with people's functional results afterwards. And so pretty much as soon as we've had low anterior resection, we've known about in some way low anterior resection syndrome. In the beginning, its definition is pretty broad. Basically, any disordered bowel function after rectal resection that causes a negative impact on quality of life. And in essence, these are the two most important parts of the definition, because you have to have some dysfunction and then it has to affect quality of life. But this doesn't really give us a very specific definition. In 2020, there's this nice publication of a consent from the LARS consortium, which defined in really very granular terms what low anterior resection syndrome is. This went through a Delphi process to reach consensus on what the definitions were. The upside of this is that it's a very comprehensive view on what low anterior resection syndrome is. The downside is that it's almost too detailed, and it includes so many elements that it's very hard to practically apply it. So for me, I basically talk about three main things, and then one kind of at the bottom. Urgency, frequency, and clustering are the things I tell patients. And I tell them this as we start talking about the operation before we do it, that urgency, frequency, and clustering are the things that people will notice after the operation. Urgency, obviously, is needing to go to the bathroom right away. Having incontinence is the worst part of urgency. So that's urgency that's so urgent you don't even notice it. That can be incontinence to flatus, or it could be incontinence to stool. But urgency, frequency, going more often, and then clustering, where people lose their reservoir and have to go to the bathroom 10 minutes later, go again, 10 minutes later, go again, and taking 3 times to do what they used to do all at once. So urgency, frequency, clustering are the mainstay. And then sort of as an offshoot of clustering is this idea of incomplete emptying. So sometimes people don't cluster into 3 bowel movements. They basically go continuously all day long in some sort of hybrid between frequency and clustering. They're all kind of related, but I think the big 3 are those: urgency, frequency, clustering. This is the LARS score. So for those of you who've never gone to this website, it's a great website with a lot of good resources for patients and doctors, but particularly patients. It has an online way that your patients can calculate LARS. It just clicks you through these screens. You can also print these out. These are the 5 questions that you have to ask to come up with the LARS score. And it involves incontinence to gas, incontinence to liquid, frequency, clustering, which is the 4th question is basically clustering, and then the 5th question is basically urgency. So this really is a way to numerically calculate what we're talking about in terms of urgency, frequency, and clustering, and it pays more attention to the frequency and to the urgency and incontinence, which I think is correct, because that's what bothers people the most. So there is a lot of weight in the LARS score towards the urgency and incontinence. You can see even these questions aren't weighted the same, and urgency is really where it's all at in terms of the score. So this is a nice, useful website that you can use if you want to have access to a nice patient-centered approach to both calculating the score and talking about some of the interventions. Now, how often does LARS happen? This is a nice systematic review and meta-analysis, because there are a lot of studies out there and the range can be pretty broad. But I think this is fairly reasonable that that major LARS occurs about 40% of the time after low anterior resection. Obviously, if you've had some of these risk factors, it's considerably higher. So the first one is long course neoadjuvant radiotherapy, a TME as opposed to a partial mesorectal excision. A leak is a risk factor. Having a diverting stoma is a risk factor. And then these last 2 didn't cross the line of significance, but are nice to mention, just TATME and J-pouch. I don't know why they included them in this table, having not reached significance, but I think if we focus on the top 4, we get to something like this, which is a simplified list of what we now accept are reasonable risk factors for LARS. If we go low, more than or less than 5 centimeters, do a total instead of a partial. Diverting stoma, and the longer you have the stoma, the worse it is. There's some newer data that says that if you shorten the interval with the diverting stoma, that the rate of LARS can be lower. So certainly this era of total neoadjuvant therapy, where people get their stomas reversed much closer to the time that they get made, should offer some improvements. Radiation therapy, that's as a single binary factor, probably the most important one. Gender, we can't really control that. And then advanced age makes these all of the symptoms worse. This is another nice, useful resource. If you haven't visited, the Pelican organization has a lot of rectal cancer resources available online, including some very nice MRI educational modules. But one of the things that Pelican houses is this POLARS, which is the preoperative risk of low anterior resection syndrome. And you can enter the following, and I tend to do this on most of my LAR patients: age, gender, whether you're doing a total or partial, where the tumor height is, whether you're planning a stoma or not, whether they've had radiation, and you can calculate the predicted LARS score. And it's difficult for patients to interpret that, but it's a little easier for us to interpret it because we know what major and minor LARS means. But this score is particularly useful in patients who are trying to decide, with a very low anastomosis, whether they want to undergo a coloanal anastomosis or maybe an end stoma. These are the things that go into the POLARS score, for those of you who are interested, because each of these questions that I've described are not weighted the same. And so I've included in the slides that I think are provided to you and will be available afterwards. If you want to look and see exactly how things are weighted, you can look here. But as I told you before, radiation is the single biggest predictor of a high LARS score. And then these other factors get weighed in as well. Sorry. And then so the other thing that you can get with a LARS score is you then get this, because it's a patient-centered tool, you get this nice visual representation of what this means. And where green is people not having any LARS symptoms, and then yellow is minor LARS, and red is major LARS. And because you can isolate this by variable, it's also useful if you're talking about wondering whether somebody should have radiation or not, as we're going to talk about in a few slides. This can help show people what the difference in terms of their function will be, whether they have radiation or not. And then you can get this, like I said, this kind of very nice visual representation for patients, which is really good. And I think that this is when you take all of the LARS data in the Pelican group, all people, all comers LAR, this is kind of where they have major, minor, and no LARS, and this correlates fairly closely with that more rigorous meta-analysis that I showed you a few slides ago. This was an interesting paper that looked specifically at LARS in Thai patients from 2016. And overall, the rates were lower than historically or otherwise reported, with a lot of patients having no LARS, but they included anterior resection in their study group. And if you take out the anterior resection, which are basically the rectosigmoid cancers, and just look at the LARs, then the major LARS score was 28.2%, which is considerably closer to the actual, what we see in general populations. The other thing that I thought I would mention here, and I would ask you guys, is whether there is a Thai language version of the LARS score. There is on that LARS consortium group has a variety of languages that the LARS score has been translated to and validated in. And this study said that they used a translated and validated version of the LARS score, but they didn't include it in their appendix. And I've not been able to find one out there. I was going to try to provide it with the talk. So interested to know from you if there are resources available to calculate LARS scores for your patients in Thai language. Okay, so for prevention, I think I wanted to talk about 3 ways that we can prevent LARS. Because we know that radiation is a factor, I was going to talk about selective radiation as a way to avoid LARS. We know that the loss of the reservoir is an issue. So, organ preservation or not doing low anterior resection is a good way to preserve, is a good way to prevent LARS. And then one that I'm particularly interested in, which is autonomic nerve disruption, which I think we as surgeons have a lot of control over. So selective radiation, I think this is probably data that's familiar to everyone. This starting with mercury, and now since Prospect was published in 2023, we now know that for patients with stage 2 and 3 rectal cancer, if you start with induction chemotherapy and get a good response to treatment, then you can skip the radiation and go straight to surgery. This is the study protocol for Prospect, which compared to a historical group that was treated like the German rectal cancer trial. And you can see that 91% of patients responded enough to chemotherapy that they were spared radiation. So if you use the selection criteria that were in Prospect, which was T2, T3s, and T3 and N positive patients, you can't do it for T4s or more advanced tumors, or with threatened CRMs. But if you follow the criteria for inclusion in Prospect, there's a very good chance that you will spare radiation for that patient. But all of them are going to have the operation. We know that in terms of loss of reservoir, we can't really replace this with surgery, whether we do a J pouch or a side-to-end anastomosis or a coloplasty. That doesn't change the rate of LARS for anything more than a very short term around the time of surgery. So really the only way to improve the reservoir function is not to operate. And we now know from the OPERA trial that if you start with, if you do a consolidation type TNT where you give chemoradiation and then chemotherapy, that up to 60% of patients can be observed. And we know that with long-term follow-up, there's a 36% regrowth rate if you follow the same criteria that they did in OPRA. And so what I tell people is about half of patients treated with this TNT strategy can avoid surgery in the long run. So if you opt for the prospect style treatment, you have a pretty good chance, 90% chance, that you're not going to have radiation, but 100% of people are going to have surgery. If you opt for the OPRA strategy, then there's a 100% chance you're going to get radiation, but a 50% chance that you're going to avoid surgery. And because LARS doesn't occur nearly as much when you don't have an LAR, many patients who are interested in preventing the functional disabilities from LARs, from lower anterior resection, opt for the OPRA strategy rather than the prospect, but they are important options to consider. And then one more mention of preserving the organ itself. The NEO trial did induction chemotherapy for early stage, that's T1 through T3 tumors, and no nodes. And if you have that, you can do induction chemotherapy and local excision and have high rates of organ preservation without significant changes in quality of life or major or even minor LARS. I wanted to talk for a second about nerve preservation, which is, I think, one of the most important things that we can control as surgeons. The innervation to the colon and rectum is shown on the left part of this slide. The vagus nerve provides parasympathetic innervation until 2/3 the way across of the transverse colon. And then S2, 3, and 4, which are the nervi erigentes, they provide retrograde innervation of the left colon through the inferior mesenteric artery blood supply to the whole left colon. And so when we do LARs, where we divide the rectum usually, divide the descending colon usually, or proximal sigmoid colon, and then do a coloanal anastomosis or colorectal anastomosis, the autonomic innervation to this left side depends on your preservation of the nerves to the left colon. So anytime you take the main trunk of the IMA, it's very likely that you're going to be disrupting the innervation to the whole left colon, which I think is a strong contributor to LAR syndrome. This is a nice detailed slide from a study looking at, from an anatomic study. On the bottom of the screen, you see the aorta. Towards the left of the picture, you see the takeoff of the IMA. And just underneath that, you see the left autonomic nerve trunk. And you can, in this study, they made it pretty clear that it's possible to dissect the autonomic nerve trunk off of the IMA as long as you can do it distal to the left colic artery. The left colic artery you see at the top of the screen taking off. If you try to take it at the base, the left trunk is pretty inseparable from this. And even if you can separate it, you're going to interrupt the course of that nerve as it travels up the left colon to innervate the parts that are beyond the vagus nerve. So my practice, unless I have a very strong reason to do it, is to try to divide this vessel distal to the takeoff of the left colic artery. And here you can see in a lot of the high ligation teaching is to take the artery here and the vein up at the inferior border of the pancreas. My strong preference is to try to take the artery after the left takeoff and take the vein at the same level. Clinical guidelines they mention LARS, but they don't really talk much about it. The ESCP guidelines say that you should screen all post-LAR patients and offer early intervention. And then NCCN notes that you should counsel about function during surgical planning. That's about all that there is out there on guidelines. In terms of management, we do a stepwise approach, starting with diet, fiber, loperamide, pelvic floor physiotherapy, then transanal irrigation, sacral nerve stimulation, and stoma. We'll talk about each of these a little bit. Again, on the LARS Consortium, LARS Collaborative site, there's some nice patient resources. There are a lot of support groups out there and online communities for this. The only caution is that a lot of people who are participating in this are are obviously having fairly poor function, and unfortunately, the people who are managing their LARS very well tend not to be part of these communities. So there is a skewed view that you get on these communities, and so anything you can do to develop some support groups within your own patient population would also be really helpful, because I find that patients who are able to talk people locally who've been through what they've been through or can relate to what they're going through tends to be really good resources. Fiber, we don't have a lot of direct evidence of fiber. We mostly think of this works because we've inferred it from all of our other ways that it's improved bowel function and other ways that it's allowed us to help manage our patients across our practice. The goal for fiber, the reason it works is because it optimizes stool consistency to make the bowel movements as easy to handle for the new anatomy as possible. Now, my own opinion is that this rarely occurs with dietary fiber. So people who tell you, oh, I eat a lot of fiber and that's good enough, that's probably not the right way to manage LARS. In LARS, you want to really work with each individual patient to figure out how to optimize their stool function to make it as good as possible. It's going to be a lot of trial and error. What you have available for you in terms of fibers are the purely soluble fibers like inulin. These are the ones that like FiberSure, I'm not sure what the other brand names are, but the bottom line of these is that anything that mixes clear into water is a pure soluble fiber. The soluble fibers that kind of gel, these are things that will dissolve in water, but they don't mix clear. So these are things like psyllium and methylcellulose, which is called Citracel in the US. These are things that will form a gel and help bulk the stools. So they're, in terms of stool consistency, they're going to help more than the purely soluble, the ones that dissolve completely. The inulins and the ones that dissolve completely, those help to fuel, through bacteria. They get translated into short chain fatty acids that also improve your bowel health and your flora in your colon and indirectly help with stools. The soluble ones that form a gel are going to actually bulk the stools. The ones that are most difficult to use are the insoluble fibers, which are the ones where you can mix them in the water all you want and nothing's going to happen. And this is most of the dietary fiber. Unclear what probiotics do. We think they're probably beneficial. It's hard to know how to use them, what doses to use, which strains to use, and it's hard to quantify exactly what that effect is going to be, but it's another thing that can be added to the trial and error list. Antidiarrheals, sometimes these optimize function. Sometimes they work by just putting on the brakes and replacing some of that lost autonomic function that might make transit times too fast. Imodium or loperamide is attractive in the US because it's over the counter. Lomodal in the US is a prescription. They both work very similarly in terms of mimicking that sort of brake effect on the colon. Two others that work in a little bit of a different mechanism is cholestyramine and cholestyramine. These are bile acid binders. Cholestyramine is the powdered form that I like to try first because it tends to be more effective. And then if it does help, then people can switch to cholestyramine and see if they can achieve the same effect with pills, which are easier to take as they get with the powder. Transanal irrigations. This, in the simplest form, this is a daily water enema. In the most complicated form, it's a system. Coloplast makes this Peristeen transanal irrigation system. Its main benefits are that it has a little bit more control of the apparatus, so that it's a little easier for a single person to do it without help. And it also includes a little bit of a balloon that can be helpful for people with LARS who, or after rectal cancer surgery, who might be incontinent to the liquid if you don't have a balloon system. So Peristeen is a nice option if you can get it, a plain warm water enema. And if you need the balloon function, doing a warm water enema with a Foley catheter is probably the cheapest way to do it. But these are useful. It requires a bit of training. It definitely requires a commitment from the patient. Usually it's done every day or every other day. And then they evacuate their bowels and they're free from symptoms for the day or two in between. There's not really a consensus on the volume or interval. So I usually start people off at about 500 milliliters once a day, and then they adjust up or down depending on how much they can hold and how easily they evacuate. And then most people go to every 2 days. Some are every 1 day, some are every 3 days, but every 2 days seems to be the most consistent. Long term, whether people keep this up or not depends on how much work it takes for them to do, and then how effective it is. And there are some people who do this religiously because they love their life when they irrigate, and there's some people who find that it helps, but it's just not worth the effort, so they'd rather deal with the symptoms as they come. Sacral nerve stimulation is one of the newer things. This is a 2-stage procedure, as you all probably know, where you can have a testing period with stage 1 to see if something works before somebody commits to it. It has very good data behind it. These are tables from a meta-analysis looking at the two real big aspects of LARS, which are number 1, the symptom, which is incontinence, and number 2, how it affects you, the quality of life. And you can see pretty much every study has a demonstrable improvement in both fecal incontinence and quality of life. So this is has been a really nice thing for people with severe LARS, and something that we should include in our toolbox. Oh, and the final slide that just got skipped is colostomy, or ostomy. It's always very difficult to create a colostomy after you've done low pelvic surgery. Sometimes we have to do the diverting stoma a little bit higher in the colon, or maybe even a diverting loop ileostomy. But an ostomy can be effective in getting people to have their quality of life back, and resolve both the symptoms and that effect. It comes at the price of a colostomy, which a lot of times people don't want until they've experienced this. But once they've experienced their life revolving around their bowel function, it is a little bit easier to convince them that colostomy will be an improvement. So in summary, LARS is very common after rectal cancer surgery and impacts quality of life. We have some modifiable things we can do, like avoiding high ligation, selective radiation, and using organ preservation. There's a lot of validated tools out there for screening with the POLAR score and following with the LARS score. So I would encourage people to do that. And if we want to do a collaborative where we can come up with a Thai language LARS score, I think that would be a nice thing to be able to offer if it doesn't exist. There's a lot of patient-centric resources and support groups out there that can be useful. And in terms of treating, stepwise is the way to go. The patient goals are really the most important part of the whole treatment. So making sure that we're going through step by step to meet the patients where they are is critical, because ultimately what we're really trying to do is improve their quality of life. And so with that, I would just like to open it for discussion and questions.
Thank you, Prof. Anterior, any question from you?
So thank you very much for your very insightful lecture. And it was truly informative and thought-provoking about this syndrome. And what do you suggest if we need the choroanal anastomosis? Is will occur every crisis?
What's the last part of the question?
The question is that sometimes we need the choroanal anastomosis. So the low anterior resection syndrome will occur almost 100%?
I think it's about 100% with coloanals. With coloanals, you often have to take the IMA at its origin because it won't reach without doing that. And so I think there's a higher risk of LARS because you're doing that. And then, of course, we know that the level of the anastomosis is an independent risk factor. So you get it from both sides, and then it just causes a little bit more sphincter dysfunction to have to do coloanal. That the people who did the POLAR score also did a shared decision-making for patients where they talked about the functional outcome from coloanal and the outcomes from having a colostomy to try to help patients who are going to have a coloanal decide whether they would rather have the functional outcome from the LARS syndrome or whether they'd rather have the colostomy, because it's a difficult choice. But I think you're right. It's about 100% after coloanal.
Thank you very much.
Dan, do you have to repeat your counseling before the ileostomy takedown? Because you get the teaching before the first operation, right? But then if you get an ileostomy takedown, that's when it really kicks in afterwards.
Yeah. My standard talk when I am consenting people for the ileostomy closure is I tell them this is a lot easier operation to go through, and other than the muscle soreness, getting out of the hospital is going to be a little bit easier. But what's going to be harder is that you're going to spend your recovery period learning how to poop again. And so I do warn them about that, and we talk to them before they leave the hospital in terms of the initial dietary guidance. And I like to tell people that, when we do our post-op call in 2 weeks, hopefully we're going to be spending most of our time talking about how you're pooping and not talking about cancer and things like that.
And how long do you give for conservative treatment before proposing, say, like sacral nerve stimulation or ostomy? Do you give them at least like a 3-month trial of physical therapy or fiber or enemas?
Yeah. So the function after you reverse the ileostomy or after they're using their LAR for the first time, their function improves dramatically for the first 3 months. And then it continues to improve for probably 18 months or maybe even longer. So I try not to do anything too drastic in the first 18 months after surgery. I try to do just diet and fiber coaching for at least the first 3 months, because time is going to be a big factor in their improvement for the first 3 months. And then for the next 6 months after that, that's when I might start adding things in like Imodium or Cholestipol in a stepwise fashion. Or if it's clear that they have pelvic nerve dysfunction or the coloanals who need some pelvic floor strengthening, you might add in some pelvic floor PT during that first, 6 months, which is basically months 3 to 9. And then for most people, they're improving along the way and you're starting to space those visits out. But for the people who are still having really severe symptoms at that point, by 9 months is when we start kind of just talking about, okay, there are some more important, you can start to do enemas if you want. And the severity of their symptoms really tells you, how willing they are to do something like that. And whether they do it or not tells you like, oh, they're really in the major, no matter what the score is, this is having a major impact on their quality of life. And then by a year post-op, if you're not making significant progress, then I think it's reasonable to start looking at some more invasive things like sacral nerve stimulation, things like that.
And then, sorry, one last question. Do you or Britta have any handouts that you routinely give patients that maybe you could share with the group on LARS?
We don't, but we should, and they all exist more on the LARS collaborative site than the Pelican site, but they are out there. There's some, it's like I showed you the little clip of that Living with LARS one. That's a whole pamphlet, or it's like 8 or 10 pages. So for people who are really having a tough time, even early on in their post-operative period, that is a nice thing to offer people.
Thank you, Dr. Kim, for asking this question for us as well. Any question from other people for Watanoso before we ask Submitted?
So may I ask another question about the list of the RAS? You mentioned about the radiation and protecting stroma. So some doctor very afraid of the anastomotic leak after the radiation, so they will do the protecting stroma. So it means that the LARS will occur twice. So how do you choose for the protecting stoma?
Yeah, good question. Avoiding the stoma is one of those things that we could potentially do to avoid LARS. My general practice is that anybody who has protecting stoma, I feel the same way, that when either the risk of leak and dysfunction, so anastomotic leak is a way, way, way more high risk factor than a diverting stoma. So the diverting stoma is kind of a protection against that part of it. Yeah, because an anastomotic leak is a powerful predictor of major LARS. So I think in that case, if you can avoid radiation, which we're doing a lot more in patients who are going to surgical management no matter what, well, either the mercury or the prospect criteria can help us avoid radiation. If they do get radiation, giving their adjuvant chemotherapy before the low anterior resection will allow you to shorten that time that they have the ostomy down to 8 to 10 weeks. So I think that that's also important. But I caution against not doing the diverting stoma in radiated patients because of the risk of LARS, because the leak is going to be much worse. So for me, anybody with radiation or an anastomosis lower than 6 centimeters gets a diverting stoma.
And how about the short course radiotherapy and the long course? Which one is the more risk factor for the LARS? Short course can reduce the LARS?
There aren't a lot of studies that compare short course to long course for LARS particularly. But I think that controlling the time interval is something that's a little bit more controllable in terms of like how long from the radiation are they going to have their stoma reversed? How long are they going to have it created? How long are they going to have it reversed? So those are all things to consider. But I don't know that, Kim, you can maybe chime in if you know more than I do on this one, but I don't think that there's any known difference in LARS or convincing data about LARS in short course versus long course. It doesn't come out as a factor in the multivariate analysis. I mean, in the systematic reviews that I saw.
Yeah, I don't know of any data that compares the two, but yeah.
Hello อาจารย์
Thank
ครับ
you.
ผมวุฒินะครับอาจารย์
Yes, Dr. Wood. Yes.
Yeah, okay. So, can I ask you one question? In case of that, we gonna do the colostomy. It mean that it's gonna be temporary or like a permanent. And in case of it's gonna be temporary, how do we know that the symptom is already subside and we can like take down close colostomy?
Yeah, I don't know that there's a role for reversing the ostomy. If you get to the ostomy as your treatment for LARS, most patients never want to go back. And I don't promise them that it's a temporary procedure. I do tell them, like, if I'm doing a higher up stoma or a diverting loop, I do tell them that it's technically reversible, but there's nothing that would make me think that it's going to be any better in the future than it is now. And what we know from the length of the ileostomy data is that the longer the neorectum's not used, the more it's going to fibrose and the less functional it's going to be. So I view the diverting stoma as pretty much a permanent solution. I don't offer reversal usually.
Excuse me. The second question is in case of the patient with the symptom of tenesmus, is the like irrigation gonna help?
It might. I think tenesmus is a little bit more difficult and might be better managed with pelvic floor physiotherapy, and your pelvic floor physical therapist can perhaps guide you in terms of what might be driving the tenesmus. If it's pelvic muscle spasm, then sometimes muscle relaxers, Valium, things like that might be helpful. We've used Botox before, and I don't know if sacral nerve stimulation is going to be helpful for that or not. But I think tenesmus is more of a pelvic floor issue than the LARS problem. So I'm not sure if the irrigation will help unless the tenesmus is occurring because of incomplete evacuation. But like many things, trial and error is kind of where we go. I mean, obviously, I would try irrigation for that patient, and then they would tell me whether it worked or not.
Thank you.
Thank you. Any question from Royal Phnom Penh Hospital? RPH, any thoughts or any question from you for him? If not, Samitivet.
Hey, Dr. Hersig, nice to see you again.
Hi, good to see you.
Okay. I just saw the Thai study that you're regarding to. So the primary investigator is my friend. When I was
That's why I
resident.
put the cover sheet on. I was hoping that you would know.
Yeah. I just asked him, and he said that this is what his paper studies when he was residency. So we trained together. We're same.
Nice.
He said that he have to find out the Thai version first, but he think he had it. And for the corroborations, those two corresponding is already like moved out from the universities. So, but I'm gonna try to figure it out. That is there any like some staff that would want to do corroborations? But once I get the Thai version, I will send the email to you.
Oh, I would like to see it. Yeah, I think it's something that could easily be published. I think it'd be a good resource for patients and clinicians, to be able to have a questionnaire that they can use in the Thai language.
I think he did had it, but he said it was 10 years ago, so he have to find it.
Yeah.
He have to look for it.
Yeah, because it could also be. I'm sure the LARS consortium would post it on their site also. They have these other ones from other languages, so.
Okay.
Yeah, thanks for reaching out. That's I figured somebody would.
Okay.
Thanks, Anita.
Yeah.
Thank you. Any other question from Samitivet before we move to Pattaya? Okay. Pattaya, any question from you, ka?
Hello, I am Dr. Pak Pong, surgeon from Smithfield Hospital. Can I ask some questions? Yeah.
Yes, please.
In case if we do the hand-sewn coloanal anastomosis, do you think it's less risk of leakage than staple at the lower area? And in case of hand-sewn, do you think avoiding stoma will be helpful like that?
I don't think there's good data about hand-sewn versus stapled. I think when we tend to make that decision, when we hand sew a coloanal, it's usually because there's no other choice. That's the only way that it could be done. And if there is enough room to staple, we will staple. So generally speaking, my decision point about sewing versus stapling is staple whenever you can, and if you can't, then or if it's too low, it's in the anal canal, you can't staple, you have to sew it. But again, I divert all of those patients. I do a diverting ileostomy in any coloanal because the risk of leak is just too high, and an uncontrolled leak is going to cause much worse functional problems. There are like Grekar had a study about very early reversal, like even a reversal within two weeks or the same hospitalization even. So I think if you were inclined not to do any stoma, it might be better to look into doing at least a short-term stoma. But I just don't trust the anastomosis until, after radiation, and when it's below 6 centimeters, I don't trust it until I've seen that X-ray at about 6 weeks, because the healing is just so delayed after radiation. And the consequences of having it not diverted are just too high. So yeah, I know there are people who do it, and they're braver than I am. But I don't think it's necessarily wrong. It's just I don't have that level of confidence.
Yep, thank you.
Pattaya, any question? Ajahn Ton, any question, ka?
Very clear. I have no question. Thank you very much.
Anyone
Thank you
else
all.
have a question?
So may I ask the last question? You see, in Bangkok Hospital, we have a pelvic floor training device used in the urology for urinary incontinence and sometimes for sexual health. So we call the QRS. I don't know if it's useful or not to use this machine for LARS.
Yeah, do you know which? Or I can look into the actual device if you want. Most of the pelvic floor physical therapy is transferable. So if something works for urinary or sexual function, it tends to also be helpful for anorectal function.
Oh, thank you. We can try this one with the Department of Urology. Thank you very much.
Yeah, if you want to share the device, I'm happy to look at it with our team here.
Thank you, Prof, for your kind offer. If no further question, we are thankful for Dr. Herzig for a very concise and informative lecture today, and we hope to see you guys again in the next month. Thank you.
So nice to see everybody again.
Yeah.
Thank you. Bye bye.
Thank you.
Thank you very much.
Willing
Sawasdee krab.
Thank you.